Community-acquired pneumonia. Community-acquired pneumonia is one of the most common infectious diseases and is an important cause of mortality and morbidity worldwide. Typical bacterial pathogens that cause community-acquired pneumonia include Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. The most common viral pathogens recovered from hospitalized patients admitted with community-acquired pneumonia include human rhinovirus and influenza. Community-acquired pneumonia is usually acquired via inhalation or aspiration of a pathogenic organism. Aspiration pneumonia is commonly caused by various pathogens. Patients with typical community-acquired pneumonia classically present with fever, a productive cough with purulent sputum, dyspnea and pleuritic chest pain. Characteristic pulmonary findings on physical examination include the following: tachypnea, rales heard over the involved low-bore segment, increased tactile fremitus, bronchial breath sounds, and echophony may be present if consolidation has occurred. Decreased tactile fremitus and dullness on chest percussion may result from parapneumonic effusion or empyema. Clinical presentation: atypical community-acquired pneumonia is often subacute and frequently indolent. The patient may have subtle pulmonary findings, non-labile infiltrates on radiography, and various extrapulmonary manifestations. Atypical community-acquired pneumonia pathogens include Mycoplasma pneumoniae, Chlamydia, influenza A and B, rhinovirus, respiratory syncytial virus, human metapneumovirus, adenovirus 4 and 7, and parainfluenza virus. The signs and symptoms of atypical community-acquired pneumonia include mental confusion, prominent headaches, myalgias, ear pain, abdominal pain, diarrhea, rash, non-exudative pharyngitis, hemoptysis, splenomegaly, and relative bradycardia. Standard diagnostic studies include chest radiography, sputum gram stain and culture, and blood cultures. There are other laboratory tests which may be used depending upon the suspected causative organism. Chest radiography is performed to evaluate for an infiltrate compatible with the presentation of community-acquired pneumonia and to help exclude conditions that may mimic community-acquired pneumonia. Patients who present very early with community-acquired pneumonia may have negative findings on chest radiography. In these patients, repeat chest radiography within 24 hours may be beneficial. Serial chest radiography can be used to observe the progression of community-acquired pneumonia. However, radiographic improvement may lag behind clinical improvement. Adequate antimicrobial therapy for community-acquired pneumonia includes coverage for Staphylococcus pneumoniae and atypical bacterial pathogens. Outpatient treatment for community-acquired pneumonia in patients with no comorbidities and no risk factors for drug-resistant Staphylococcus pneumoniae frequently includes a macrolide and doxycycline. Treatment in patients with comorbidities such as chronic heart, lung, liver, or renal disease, diabetes mellitus, alcoholism, malignancy, asplenia, immunosuppression, prior antibiotics within 90 days, or other risk factors for drug-resistant infection include respiratory fluoroquinolones and beta-lactam or amoxicillin clavulinate, or ceftriaxone, cefpodoxime, or cefuroxime plus a macrolide or doxycycline. For hospitalized patients, therapy consists of beta-lactams plus a macrolide or respiratory fluoroquinolone. therapy in ICU patients includes beta-lactam plus either macrolide or respiratory fluoroquinolone. For patients with penicillin allergy, a respiratory fluoroquinolone and aztreonam may be added. If Pseudomonas is suspected, therapy includes anti-pneumococcal and anti-pseudomonal beta-lactam plus ciprofloxacin or levofloxacin or beta-lactam plus aminoglycoside and azithromycin or aminoglycoside and fluoroquinolone. For patients with penicillin allergy, aztreonam instead of the beta-lactam in the regimen listed above. If methicillin-resistant Staphylococcus aureus is suspected, vancomycin, linezolid, or ceftaroline should be added. Complications in community-acquired pneumonia depend on the infecting pathogen and the patient's baseline health. It includes empyema, precipitation of myocardial infarction and pneumococcal sepsis. Morbidity and mortality associated with community-acquired pneumonia are most common in elderly patients and immunocompromised hosts. Negative prognostic factors in community-acquired pneumonia include pre-existing lung disease, underlying cardiac disease, poor splenic function, advanced age, multilobar involvement, and delayed initiation of appropriate antimicrobial therapy.